I've discussed with Dr. Vasant Nagvekar and tried to look into things that we are going to discuss is what we actually practice in our day-to-day practice, especially in the critically ill patients. First, moving on, what is new in the diagnostics. Second is, as usual, we see the MDRs that we have to treat in our ICUs. So how we treat them. And the critically ill patient, the most hot topic which we are always facing and we are trying to work around in our patients is on use of cytosol. And lastly, if we have time, we'll also cover candidemia. So to start with, in the investigations, basically all patients who come to the hospital and in the ICU, we are dependent on few of the investigations. So one of the things which was the article in one of the 10 reviews, which was selected from the annual update in Intensive Care and Emergency Medicine 2023 was on metagenomic sequencing in the ICU for precision diagnosis of critical infectious patients. So this patients, basically metagenomics is the study of nucleotide sequences from all organisms in biological samples, infectious diseases, bacteria, viruses, and fungi in a single test without a need for the culture. So the term metagenetics refers traditionally to the DNA sequencing, whereas meta-trigenomics refers to RNA sequencing. Next slide, 1 minute. So basically, when it comes to investigations, we know over the years we have gone through it's with cultures where we have the growth and isolation of species present in a sample. Its cost is not so much, it's low moderate, but some here the microbial detection is through species which are difficult to, some species are difficult to culture and cannot be cultured, and additional considerations that need to be looked into is it is medium dependent and prior use of antimicrobial agents will affect the sensitivity. Turnaround time is days to weeks. Immunological methods, the detection is by antibodies and antigens. Again, it is determined by the choice of the antibody or the antigen, and antibody testing may not be useful during the acute disease, and it is also limited by sensitivity and specificity. Minutes to days is what we get the studies. And PCR is targeted to amplification of specific pathogens. Again, it is limited by PCR primer panel, and it detects only a few pre-selected microbes. Some species might be preferentially amplified. Turnaround is minutes to days. Yes, metagenomics is nucleotide sequences, capture and amplification. Its cost is high, it is unbiased, and the host background will be the dominant, and it will give a turnaround in hours to days. The principles of this is that the sample is collected, and then there is a nucleic acid extraction from that sample, library preparation and sequencing. And then this sequencing part is again it reads into a sequence data and fed into a bioinformatics pipeline. And then this goes for quality control, host subtraction, and taxonomic alignment. So this will then give us the identification and the quantification of the microbial species and the functional analysis. There are case examples where this metagenomics for the diagnosis has helped in identification of disease-causing organisms in all kinds of infections, whether it is in CSF for CNS, plasma for sepsis, respiratory infections, so all through BAL, pleural fluid, tracheal aspirate, abscess fluids, peritoneal fluids, urine, and joint fluids. In the cohort of 350 patients, a 94% concordance between blood culture and plasma-based metagenomics testing was reported. In a study of 193 patients with sepsis, a higher rate of pathogen detection was reported using metagenomics, 85% when compared to culture, 31%. It has been also employed in hospital settings for distribution of resistant organisms to study that. And also it is demonstrated utility for antimicrobial resistance prediction in critically ill patients with pneumonia. In 221 critical patients, it identified 95% of sepsis cases with positive microbiology, predicted sepsis in 74% of the suspected sepsis cases with the negative conventional microbiology, and was consistent with the diagnosis of sepsis in 89% of unclear sepsis cases, which is what we come across. The limitations of this study is there is a lack of definitive clinical trials in utilizing this. Few laboratories with the infrastructure needed to afford the rapid turnover, and cost is definitely one of the factors. And only few metagenomic assays have undergone the clinical validation needed to permit use in patient care. Dr. Nagvekar, you can go ahead from here.
Right. So I think the four methodology which Darshana mentioned was, one is a conventional culture, which goes without saying it's very accurate, and looking at the patient's clinical status, we can do that. Immunological I think because you have to interpret it with some. The way forward after culture is the PCR based test and the
I think, sir, there's a network issue. Not very clear.
metagenomics. What can is not clear? Can you hear me now? Hello.
Now it
Vasant,
is
you may
clear.
need to shut off your video.
1 second.
Bandwidth issues.
Okay. Now, yeah, Subra. So
That's better.
my question to you was, how much you're using PCR based test and what is the relevance of that in your clinical practice, and any experience with metagenomics, and in case if it's available in future, what is your take on this subject?
So everybody's using technology today, whether it's PCR or gene sequencing, and a lot of technologies started to become available. So we all know that PCR and such very sensitive tests are very, very dependent on how good the quality of the sample is. And there's always a post-test interpretation that goes into it. And that's a big issue. So as long as blood culture contamination rates are significantly high, these tests are not going to really add value because you're going to get a lot of garbage. The second thing is that remember, during any illness, things like CMV will be overexpressed. And therefore, finding CMV and things like that is not necessarily a problem. And that might actually induce a person to start treating for things which are not really going to make a difference to the outcome. So obviously, there are certain educational issues that need to go into it before we start using this technology. But the answer is yes, it's a good idea. In my clinical practice, I'm already using gene sequencing to a significant extent, like 16S and ITS. And 16 has been very well validated in certain areas, especially bone and joint infections, and possibly even bacterial CNS infections, where it's shown significant benefit and in identifying pathogens. And I think this is an extension of that. Obviously, the cost issue here is very high. So the setup cost is going to be high. And also, like I said, at the back end, there is going to be interpretive issues that need to go into it. And remember that the identification is only as good as the library that we have. So when people look at the identification based on genomic studies, you need to look at the percentage fit. So if the percentage fit is low, that means the identification at a genus level itself is questionable. On the other hand, if the identification is at a very high level, let's say 99.3% or so, then it is very accurate when it comes to genus and species level. So there are quite a few things which go into this, but I think it is exciting technology which could be part of the answer going forward.
Yeah, thanks, Subra. Thanks for that elaborated answer. I next is Bharat. What's your experience? Because I think Dinanath Mangeshkar does a lot of these 16S RNAs and all that. Any experience of yours using the metagenomics directly from the blood sample for patients who are in sepsis? I mean, any trials from that and at Dinanath Hospital?
So we do it at our place. The only thing is that we have limited the use of genomic sequencing only to samples obtained from sterile sites. Because if we get samples from respiratory tract or urinary tract or from some wound surface, it is going to pick up a lot of background noise, as Dr. Subra had suggested. So it is becoming very, very difficult to interpret those reports. And next thing is the turnaround time is not as less as we think. We definitely the turnaround time can be from 6 days to even 1.5 months sometimes, because the interpretation of that we have got the next generation sequencer over here. So it literally picks up so many sequences that out of which are clinically important becomes a difficult task. And it's a learning curve for us, learning process for us. However, we have been able to diagnose a few cases of bacterial endocarditis, which were the cultures were sterile and the wall tissues were processed. We've been able to diagnose certain prosthetic joint infections, some cases of septic arthritis, and some cases of CNS infection. But its a utility is limited. We have to really interpret them with caution, because now I tell you one example that one case of spondylolischitis, it picked up a fungus called as Rhodotorula mucilaginosa. So what I mean, when I searched the literature, we found that it is a fungemia happening in neutropenic patient with this fungus, but never been reported as a cause of spondylodiscitis in any patient. So we have ignored that report, and the patient is still doing well. So sometimes you have to really ignore few reports and take into account some reports. So it just requires a bit of pinch of salt also to interpret those reports.
Yeah, so I think what we are looking at it is the rapid test in the intensive care unit for us to quickly identify the organism, and even if we know the organism, maybe the resistance pattern and the susceptibility will be later on. So here, what we are seeing is the 16S RNA. What we are doing, even if we have adequate samples to run the test, it will take minimum 48 to 72 hours for us to identify. But I think what we are looking at is whether directly from the blood sample, especially sepsis part, whether we can be able to identify whether we can extract the DNA quickly and say like 6 to 12 hours the turnaround time, where your blood cultures conventional would take at least 18 to maybe 48 hours if the patient is bacterial to identify. So that's what. So, but yes, metagenomics is quite exciting, and I think we look forward to this when it comes into the system available. Will be our personal experience would tell us how good it is or bad it is. And as I think Subra and everybody, Bharat has said, the sample is very important. Sometimes if you're taken from the ball or unsterile site, it may give much more number of organisms, and it will only confuse us more than required. Yes, but the way forward possibly would be to go for metagenomics. Darshana, we can go for the next paper.
So next is on the infectious disease IDSC guidance on the treatment of extended spectrum beta-lactam is producing Enterobacterales and carbapenem resistant Enterobacterales and Pseudomonas aeruginosa with difficult to treat resistance. So the slide is, so goal is to assist the clinicians, including those with and without infectious diseases expertise, in selecting antibiotic therapy for infectious caused by these organisms. The recommended antibiotic treatment options for presumed or confirmed extended spectrum beta-lactam is producing Enterobacterales, assuming the in vitro susceptibility to agents are described over here. So in cystitis, preferred treatment, nitrofurantoin, trimethoprim, sulfamethoxazole. Alternative treatment, if the first line options are not available or tolerated, is amoxiclavulinic single dose, aminoglycosides, fosfomycin, or the quinolones, ertapenem, meropenem, imipenem, and the cilastatin. Pyelonephritis or complicated urinary tract infection, a preferred treatment, again, the carbapenem, ciprofloxacin, levofloxacin, or the trimethoprim sulfamethoxazole. An infectious disease outside of the urinary tract, meropenem, imipenem, cilastatin, ertapenem. Oral step-down therapy to the quinolones or the Septran should be considered. The recommended antibiotic treatment options for carbapenem resistant Enterobacteriaceae, assuming in vitro susceptibility to the agents. Again, here the pyelonephritis, complicated UTI, ceftazidime, avibactam, meropenem, varobactam, imipenem, cilastatin, and all those things. And if meropenem is used only if it is a ertapenem resistant, then meropenem, or only if ertapenem resistant, that is an extended infusion of meropenem only if ertapenem resistant or meropenem is susceptible, and carbapenem testing results are either not available or negative. And otherwise, alternative treatment is once a daily aminoglycoside. Then infections outside of the urinary tract is which are resistant to the infections outside of the urinary tract is again meropenem with extended infusion, or alternative treatment is ceftazidime avibactam. Infections outside of the urinary tract, again, resistant to ertapenem, resistant to meropenem, and carbapenem testing results are either not available. There's ceftazidime avibactam, meropenem, varobactam, and meropenem and imipenem cilastin, relibactam. And alternative is cefiderocol or anticycline to be added if it is abdominal infection. Klebsiella pneumonia, carbapenemesis is identified for carbapenemesis positive, but in this patient, ceftazidime avibactam, meropenem, varobactam, imipenem, celestin, relibactam, and otherwise an alternative is cefiderocol and tigecycline for abdominal. And then comes the metallo-beta-lactamesis, NDM, VM, and IMP. Carbapenem is identified. Here, ceftazidime, avibactam plus astronam or cefiderocol, and tigecycline to be added for abdominal. And then comes the OXA 4B like carbapenem is identified, where it is ceftazidime and avibactam or cefiderocol, which is the and tigecycline again if it is a abdominal. And the last one is recommended antibiotic treatment options for difficult to treat Pseudomonas aeruginosa, assuming in vitro susceptibility. Here cystitis, it is ceftolozane, tazobactam or ceftazidime avibactam, and imipenem relibactam, cefiderocol, or a single dose of an aminoglycoside. Alternative is colistin. Pyelonephritis or complicated UTI, it is ceftolozane, tazobactam, ceftazidime avibactam, imipenem, celestin, alibactam, and cefiderocol. Once a day, otherwise alternative treatment once daily aminoglycoside. And infections outside of the urinary tract is again the same that we spoke about, and otherwise cefiderocol. So from here you can go ahead.
Yeah, so I think I want to ask Shalmali, what is your preferred choice as outpatient therapy for PSBL urosepsis and for your patients who have pyelonephritis who get admitted to your hospital?
I'm audible now, sir?
Yes.
Yeah. So if it is ESBL, which is sensitive to a carbapenem, then if it is an outpatient therapy, then if it TMP-SMX susceptible and it is uncomplicated, then I would prefer TMP-SMX, provided the patient is not sulfa allergic and the rest of the parameters are okay. Otherwise, I could use ertapenem as an outpatient therapy for these if they are ertapenem susceptible. For inpatient, I prefer carbapenem like meropenem for inpatient therapy.
So, what about piperacillin tazobactam or the BLBLI inhibitors for your?
Sir, if I have started the patient empirically on piperacillin tazobactam before I get the cultures and the patient is responding to it, then I would continue piperacillin tazobactam. But otherwise, I would prefer to use a carbapenem.
Yeah. So, Raman, is there a concern about piperacillin tazobactam as a drug to be used for ESBL, even if it is showing susceptible before to the patient? And that is my first question, and I'll come to the second question.
The problem is that whether the use of piperacillin tazobactam or cefoperazone sulbactam leads to increased failure rates in patients with ESBL. Now, I would rather place this question in a practical aspect. The choice is between giving a BLBLI and a carbapenem in most circumstances. Now, patients with mild to moderate infections who are admitted in wards or are on outpatient basis, they seem to have very low rates of failure with piperacillin tazobactam or cefoperazone sulbactam. So I'm quite comfortable using these drugs for patients with mild to moderate infection. In a patient who is severely ill, who is in a critical care unit, has organ failure, the choices are, of course, in clear that you go with a carbapenem. So, despite multiple guidelines advising against use of piperacillin tazobactam and cefoperazone sulbactam for patients for urinary tract infections, for mild to moderate infections, I believe there is still a role for this, and the ease of use. For example, giving the other problem is using a carbapenem predisposes patients to having carbapenem resistant infections either. I regard meropenem as the most dangerous drug available in the ICU. Patients who are on meropenem go on to have complicated courses for some reason, whether it is cause or effect. I am not really sure about that. So yes, for mild to moderate infections, I believe that cefoperazone sulbactam and piperacillin BLBLIs are still a good choice to exercise.
Yeah. So there was some concern about piperacillin tazobactam because though it is showing susceptible, the MIC's interpretation and all that is still a question mark. But if the patient is clinically improving, possibly you would continue. But in spite of it showing susceptible, if the patient is not doing well, then I think there's in vitro and in
So-
vivo, there is a concern about the
Yes.
interpretation of these MICs and yeah, Raman, yeah.
There may be clinical failures, and the clinical failures may be with either antibiotics. For example, if the lab reports something as susceptible, not 100% of our cases are going to respond. If it is going to be reported resistant, still up to half of the patients may be responding to antibiotics. So a patient may have Pseudomonas carbapenem resistant, and he may be responding transiently to cefoperazone sulbactam or something as well. So I believe that despite the concern about BLBLIs, there is a role for then. If we are going to rule out these antibiotics in the first place, then the only choices left to us are really carbapenems. I'm sure each of us are using these antibiotics for.
Correct. So, Subra, a question to you is nowadays we are seeing that cephalosporin sulbactam resistant, piperacillin tazobactam resistant, ertapenem, MIC is one intermediate or resistant, and meropenem sometimes it shows two, okay, and it's an E. coli or it could be an Klebsiella, but meropenem is showing as intermediate. So, in this scenario, multiple questions. One is would you still go ahead and patient has come with pyelonephritis? You have started with meropenem, and the MIC is 2. And option is whether role of these when you have higher MICs. What are the other options from apart from meropenem? Sparing the colistin and the ceftazidime-avibactam or ceftazidime-avibactam aztreonam. So, do we have some sparing regimen which possibly may not be available in India? But will that be having some role in India, like meropenem, merobactam, or imipenem, relibactam, which do not cover the NDM or the NBLs, but may have role for the ESBLs, which are possibly having a higher or intermediate for meropenem, where you want to not use your weapons like phosphocolistin or ceftazidime-avibactam or ceftazidime-avibactam plus aztreonam. So, your thought process and what would you do if you have a patient with a meropenem MIC of 2?
Okay, Vasant, you'll have to give me as much time as the question was worded because
Yes,
it's a very difficult question. All right, no, but I love this. This is a very good question, and I want to echo what Raman just talked about. This fascination for vitamin M is probably something that is really toxic, and we need to get off. I noticed that in many hospitals today, there are no contraindications to vitamin M. There are no indications for vitamin M. There are only contraindications. Almost every patient in the ICU is started with vitamin M, and that has to stop. Why? Because that really fosters this problem of carbapenem resistance. I've stopped using it as meropenem. I'm calling it vitamin M these days because it's being used that way. Now, what do we do in a setting where you have this? Obviously, data is king. So for a long time, my microbiology was very nice about it, and they were able to do all kinds of tests on this, where they used to do eSIM, MSIM, and all that stuff to try and find inducible carbapenemases. This was before we started doing CARBAR, and even when we were doing CARBAR, we were doing this as a backup. Because in Klebsiella, there is some very curious phenomena that happen when you have heterogeneous populations and things like that. Long story short, the point is you may be able to get away with meropenem simply because of the 90-60 rule, where if it is susceptible, 90% of the time it works. If it's resistant, it still works about 60% of the time. But having said that, the question is, can we get away from this toxicity of vitamin M? The answer is yes. So for community-acquired respiratory infections, people are still using meropenem. I don't know why. In my hospital, we are consciously pushing everybody away from meropenem to ceftaroline for our sick patients because we want to use less carbapenems. The second thing is for urinary tract infection and for line-related infections, the other option of not using a beta-lactam is actually an aminoglycoside because your bloodstream levels are very good and your kidney levels and urinary levels are phenomenally good. Aminoglycoside and its nephrotoxicity is significantly overstated, and it's something that we should be not too worried about. There is only one real contraindication of aminoglycoside, and that honestly is patients with Eaton-Lambert syndrome or myasthenia gravis. Unless you have that, there's really no contraindication to using aminoglycoside, you just need to adjust for it, do blood levels if you can have that option, which I think will be really nice, and start using more aminoglycoside. And the great thing with aminoglycoside is that they have very different resistance pattern. Just because you've lost gentamicin, it doesn't mean amikacin will not work. If amikacin does not work, cobra may still work, nettle may still work. The new aminoglycoside that's coming out, plasmamycin, that may still work, and so on and so forth. MBL producers generally tend to be very resistant to aminoglycosides because of the co-production of aminoglycoside modifying enzymes along in the plasmid. But having said that, that's not a 100% phenomena. So therefore, I always try and see if we can bank on aminoglycoside, and that's something that does give very good benefits, because honestly, more people die of septic shock than they do of kidney toxicity in the ICU. So aminoglycosides are one option. Could I use cotrimoxazole in this setting? Obviously, there's not really good quality data looking at IV cotrimoxazole in the setting of an ICU patient with pyelonephritis, but I would certainly think of it as a step-down therapy for selected patients, and I have used it. But yes, it's a little uncomfortable using that. Would I use cefiderocol and things like that? I call cefiderocol as a Maha-tigecycline. It's got the same warnings tigecycline had, where it said if your patient is bacteremic and the patient is sick, they're more likely to die and things like that. So cefiderocol has turned out to be a reasonably unreliable option. Finally, the other option that I think we should still think of would probably be chloramphenicol as well, because we are trying to have other non-colistin or non-ceftazidime based options, not for urinary tract infection, for certain other infections. Chloramphenicol IV could be an option. Chloro IV is a lot less toxic than oral chloramphenicol. I do use it from time to time. Great penetration in many, many places, and it works very well. So that could be a part of the answer as well. But the short answer is that we need a basket of resources and not just be a one-trick pony where we say everything meropenem, everywhere meropenem, everybody meropenem. And that's exactly what gets us into trouble. And I'm worried that the same philosophy is repeating with ceftazidime all over again. Everybody ceftazidime, every time ceftazidime, every situation ceftazidime, and I don't think that's healthy as well. Of course, when we take ceftazidime, it has to be ceftazidime with astronam till we know better. But I think that approach is also significantly unhealthy. And the idea is to try and see if we can come up with a basket of resources and try and get off. See, even if you start up front, the important thing is that 48 to 72 hours, you should be saying, how do I change? So even if you start ceftazidime based therapy in 48 to 72 hours, you have to ask yourself, can I change it to something else? And if that aggression is showed, then the problem is also significantly mitigated. Unfortunately, there's a lot of inertia in wanting to change from what we think is a winning horse, and that is causing a lot of grief.
Yeah, so Bharat, the same question I'm taking to you. Like, meropenem, the MIC is 1 or 2, and anyway, meropenem is now going to be in this patient in future is not going to work. But if you want to avoid colistin, and of course, Subra has given nicely a lot of other options, which like aminoglycoside, chloramphenicol, Bactrim, trimethoprim, sulfamethoxazole, and all the reserve drugs. So anyway, meropenem is going out of the basket with the MIC of 2, where the breakpoint is 1, or let's say it is 1, and just adding varobactam or something, anyway it's going to die, but supporting with that varobactam or say like imipenem, rilibactam, where imipenem MIC is also similarly 1. Will that be an option in case if these drugs are available in future? Because I always had that thought, because I do see a lot of patients with ertapenem resistant, BLBLA resistant, and meropenem MIC 1. Because of so much of vitamin M, as Subra has said.
Yeah, sorry, I lost your question because this was connecting to this Bluetooth. And there are some people in my house who are making a lot of noise. So I lost your question. So can you please repeat in a short?
Then I said ki meropenem MIC is 1 or 2, that is just intermediate. Okay. And meaning, is there any role where you can want to salvage? The Subra has already given us choice of aminoglycoside, chloramphenicol, all these reserve drugs, which will be very, very useful. Where because of using a lot of meropenem, your MICs are rising, and to save the other drug like colistin, ceftazidime, avibactam, and all that, whether meropenem, varobactam, or imipenem, rilibactam would be of any use, which are not available in India, but just for a theoretical discussion, not cephalic.
Yeah, I mean, for urinary tract infection, definitely aminoglycoside can be a carbapenem sparing choice. about if the strain is intermediate, you can still get away with its use in the urinary tract. I mean, if you want to still use meropenem in the urinary tract, we can still get away with it with an intermediate MIC. I don't know whether that holds true for bacteremia or whether that holds true for septic shock. Then definitely would like to use an antibiotic which is fully susceptible and not an intermediate one. About this meropenem, bavobactam, and imipenem relebactam, I believe they are of less of use in our settings because of the Indian problem. So they are not that useful, because if it was only OXA or KPC kind of problem as we find in the Western countries, then they could have been a better option.
Thanks, Bharat. I think one more question, Darshana, to Dr. Shalmali, and before we move to the third paper quickly. So, Shalmali, what about CRPA, like carbapenem resistant Pseudomonas aeruginosa? What are your options? And suppose if cephalosporin tazobactam was also available in India, and you have the organism only susceptible to polymyxins, how would you go about treating this?
So the problem with Pseudomonas is that our Pseudomonas is not sensitive to ceftazidime avibactam, or even only some percentage of Pseudomonas will be susceptible to addition of astronam to ceftazidime avibactam. So we're not left with a lot of choices where Pseudomonas is concerned in India, because of the non-availability of many of the other drugs like cefiderocol or ceftolazone tazobactam. So that's why we are left with only colistin-based therapy as an option for Pseudomonas, and polymyxin-based therapy as an option for Pseudomonas. So that is the problem.
So the problem with ceftolazone tazobactam is that majority earlier our Pseudomonas were Vim. Nowadays, majority of the Pseudomonas are Indian. So once you have NDM, even the ceftolazone tazobactam goes out of the market, and you're left with colistin and maybe the newer drug from Cefepime, which is a phase 3 trial. Cefepime.
So Cefepime zidibactam, sir, we have had some experience with Cefepime zidibactam, but it was a Pseudomonas which was causing otitis media.
Correct.
And it was MDRO, and with that, because the procurement of that drug takes about 3 days.
Correct.
So because it takes about 3 days, sepsis is out of question, because by that time the patient will die. So, but in otitis media, MDRO Pseudomonas, the patient did do well. So I'm hopeful that it works.
Right. Thanks, Darshana. Just I think one more paper of yours.
Yeah, yes. So yes, so we'll only go through one because just last 10 minutes. So I'll be fast.
Yes.
It's not moving. So this is on adjuncting hemoadsorption therapy with cytosop in patients with septic vasoplegic shock, a best practice consensus, because this is something which we really want to see in our patients who are in severe septic shock. This paper, the entire details, they have gone into every depth, from the properties to the effects on circulating cytokines to the effects on cytosop therapy on clinical parameters, the patient selection and timing. In fact, the patient selection and timing becomes the most important, because there it is a dilemma when it is to be started, which are the patients to be selected, and they've given a dynamic scoring system which is helpful, which you take the score, the details of the parameters at T0, that is at the immediate when the patient has come in septic shock, and after 6 hours, and based on that you can take a call, and dosing, which is on the amount of blood purified, how much should be the goals, and therapeutic goals include everything which we normally have, including reducing the use of CRRT and including reducing the use of ventilator, and on the length of stay of the patient. The safety, which is mostly related to using this cytosop, whether some of the drugs which are interacting and whether we need to give extra doses of certain medications. Procedural details, it covers that whether this can be used with the circuits which are like the extracorporeal ECMO and CRRT and all, which has been proved over here. And then the anti-infectives doses and anticoagulation. So in this conclusion, they have summarized, based on the conclusion on this expert consensus, they have given some recommendations on hemoadsorptions. And these are the suggestions, that is the patient selection, consider in refractory septic or vasoplegic shock, unresponsive to the initial line of therapy. And patients should have obvious signs of ongoing hyperinflation. And if available, soluble markers of inflammation should be clearly elevated, that is IL-6, PCT, ferritin. Timing start within 12 hours, but not later than 24 hours after diagnosis. Dosing change adsorber every 8 to 12 hours during the first day of therapy. and later changed every 48 hours. This they are actually maintaining, saying as loading dose and maintenance dose. Maintain the therapy until hemodynamic stabilization, where it is norepinephrine dose comes down to less than 0.05 micrograms per kg per minute, and concomitant medication, that is the drugs like anti-infectives, you have to increase the dose or give additional doses after 1 to 2 hours after the initiation, and if possible, if required, then use the therapeutic drug monitoring. Sir, you can go ahead from there.
Yeah, so I think I just put it open to all the panelists. I just give a classical example of a case which we had. The patient is a post renal transplant done in 2014, doing extremely well and having repeated UTIs, but having a fairly decent creatinine of normal creatinine, rather, I would say. But having yeah, so
They have, I mean, just the chair is little.
hello. So, having a fairly normal creatinine, and she has been exposed to multiple time antibiotics. So, her first urine culture before she had done, she got admitted to a hospital, was already done outside, and that showed OXA 48, and it was Klebsiella, which was sensitive. So, this patient was started on ceftazidime avibactam, and only what happened was next day morning, this patient became more septic, and there was one more report, say 2 months back, which had shown that this Klebsiella was also NDM plus OXA. And the patient fever persisted, she was slightly restless. So cholesterol was added and the creatinine started rising, so urine output dropped even before the cholesterol was added. In the evening, this patient went on one inotrope, ventilated on CRRT because there was complete anuria. So gradually in 24 hours, in spite of having a sensitive bug, this patient quickly developed. So what do you think about the role of this cytosol in the patient who has a sensitive bug, USG done and CT done, does not show any obstruction, does not just show pyelonephritis, does not show any renal abscess, no complicated pyelonephritis. It is just a pyelonephritis in a immunocompromised patient and rapidly going down in spite of getting the correct antibiotic. And finally, by the next day morning, she was on 3 inotropes. So, in spite of having correct treatment, she was clinically not. So, what is the role of this cytosol? What Darshana wanted to discuss in this case? Is there a role in this patient? It's open to all the panelists. Anybody? The patient is on 3-inotrope, cytosol, on CRRT and looking very sick, not responding to the medical line of treatment. But maybe it's too early for the medical line of treatment to work, whether we require some time to be given. It's open to all the panelists.
So, I will take a contrarian standpoint. Now, I have this running argument with our intensive care and nephrology, whether this thing works, this cytosol therapy works. They say when these patients are sick, they are put on CRRT, SLAD, and some cytosol, and next day some of these are well, and they say that the cytosol has worked. Now, my main argument against blood purification and cytosol is the biological plausibility argument, which means that look, these cytokines, inflammatory cytokines, the main mechanism of action is autocrine and paracrine, so that it acts over small distances. The cytokines we are picking up in blood mostly represents a spillover from the tissue cytokine levels, right? Removing these really makes no sense because they are just an effect of what is going on elsewhere. The cytokinemia is per se itself not responsible for the sepsis element. Rather, the endothelial activation, the local inflammatory cytokines in the tissue are what is important. So how does it make sense removing the cytokines in the blood and expect it? It's like the arguments of old blood purification, leeches, which we used to use, like the medical practitioners used to use 200, 300 years back. Maybe that's where we are, Dr. Subra.
Yeah, Subra, your comments.
Yeah, no.
Then Bharat and then Shyam.
Yeah, definitely. I think Raman has raised an important point. Many of the people who are listening to this and may actually watch this a little later on are probably not been in the field for maybe about 20 years. So those of us who've been in the field for more than 20 years will remember the story of drotrecogin alpha or activated protein C, Zygris as it was called. Came out with much fanfare where it said, you modify this, it makes a huge difference. And the number needed to treat was 8. You treat 8 patients, you save 1 life, which I think was incredibly small number needed to treat. And subsequently, studies have shown that it really didn't work at all. So the point is that when we are trying to do a modification at a molecular level, we should be very careful whether the theory that we have will fully explain what's happening. Please understand that sepsis and septic shock is a very, very, very complicated pathophysiology and is not just by one marker or two marker, and it's a delicate balance between various players, both pro and anti, and both of which are required. And I think trying to fool around with that and expect a simplistic answer may not necessarily be the right model we should be looking at. And I think that's a bit of a problem. The second thing is, I think unless we see clinical data in terms of clear endpoints, I think it's going to be very, very difficult. As of right now, I know this question has come up many times. I've discussed it with intensivists and some of my own colleagues. I am going to sit on the fence and say at this point, I would classify this as experimental, and I'm going to wait for more data to come through after all the brouhaha about activated protein C.
A quick one comment from Bharat, and because we already overshot the time, and one comment from Dr. Chalman.
Yes, so the comment about drotrecogin alpha was that there was one more player who used to decide. A company man used to come and then decide whether this drug is indicated in that particular patient. So that something was another decision maker was there. So that was one unique point about that drug, and thankfully it has gone out of market. About the cytosorb, it may not be absolutely useless. You have to carefully see a few patients and a few more data before actually accepting it or even outright rejecting it, because it has a theory that it will absorb certain cytokines which are associated with shock. And initially, I think we also used to use some polymyxin absorption dialysis. I remember that being used sometime back in one of the ICU in the city. So I mean, it may not be absolutely useless, but it may not be as much as useful as the product manufacturer, claims. So we have to really see for a few months before saying plus or minus about this product.
Thanks, Bharat. Shalmini, your comment?
Sir, I don't doubt that the inflammation, the pro-inflammation that occurs during sepsis is the main problem when you are having a sensitive. So it may not just be the infection, but the severe inflammation that infection causes, that causes the patient to go down so rapidly. Whether cytosorb is the answer to it or not, I'm not sure, because we don't have that much data on that. But we definitely need some modality to reduce that inflammation and buy us time for our antibiotics to act and get the patient better.
Right. I think still an experimental phase, doubtful result, but I think everybody have their own data to know where it works or not. I think I hand it over to Darshana. Darshana, I hand it over to you for your comments and closure. And Avinda, finally.
So we are already over time. So therefore, I think with these 3 papers, we'll have to end over here. Arindam, you have to say anything?
Thank you all. And just to inform, sir, we would also release a small sort of abstract of it, and we would be certainly need your help to edit this the portion. And this was just the beginning, and we would be doing. You are doing lots, sir, already. We would be collaborating with SEEDS and along with the ISCCM, and we would also have certain other programs. So thanks again, Dr. Subramaniam sir, Dr. Raman sir, Dr. Bharat sir, and nice to see Shalmali after a long time. Thanks for joining, and obviously both to Dr. Darshana and Vasant sir. So see you sometime soon on this. Thank you.
Thank you to all of the panelists and sir. Thank you. Thanks. Bye.
Take care. Stay safe.